This is Rural Health Leadership Radio.
Episode 179, a conversation with Grace Ann Dorney Koppel, president of the Dorney Koppel Foundation.
Anyone who breathes, actually, can get COPD because we have this very large number, 25% of people who've never smoked cigarettes.
Welcome to the Rural Health Leadership Radio with your host, Dr. Bill Oxier. Each week, Dr. Oxier has a conversation with a different rural health leader to discuss what's working and what's not working in rural health, along with other topics of interest to rural health leaders. Rural Health Leadership Radio's goal is to improve health in rural America by providing a simple, no-cost means to share information and connect rural health leaders from around the country. And now, here's Dr. Oxier with today's guest.
Hi, everybody. I am your host, Dr. Bill Oxier, and welcome to the Rural Health Leadership Radio podcast. I want to wish all of you a happy new year to you and yours, and I hope you had a great holiday season and are ready for an incredible year. Now, I don't know about you, but for me, it's hard to believe that it's 2020. Is that hard for you as well? You know, while time marches on, that does make it even more important for us to share best practices here on Rural Health Leadership Radio. And today I'm so excited for our guest to share information that's going to assist rural health leaders with best practices as it relates to chronic disease management, COPD in particular. Now, this interview took place several months ago as part of a project that the National Rural Resource Center put together for chronic disease management. And I want to thank them for allowing me to have a small role in that project and for making today's episode possible. Now on to today's guest. Today we're having a conversation with Grace Ann Dorney Koppel, president of the Dorney Koppel Foundation, immediate past president of the COPD Foundation, and currently a board member of the COPD Foundation, chair of advocacy and policy. Welcome to the Rural COPD podcast, Grace Ann.
Well, it's good to be here with you, Bill.
Tell us about yourself. Who is Grace Ann Dorney Koppel? What is your story?
Well, Bill, there are at least two versions of Grace Ann Koppel. There is the Grace Ann Dorney Koppel, a mother, a lawyer, a teacher, a behavioral scientist before 2001. And then there is the Grace Ann Dorney Koppel after a diagnosis of COPD in 2001, which really changed her life. Well, after that diagnosis and the realization that I had an incurable but treatable disease, I was fortunate enough to get a prescription from my doctor for pulmonary rehab. And that set me on a course of action that brought my life back to where I had hoped it would be, and it led me on a course of advocacy and action so that the best treatments for my disease would be available to everyone who had that disease.
It sounds like an interesting journey, Grace Ann, and one that has many consequences, but it sounds like you're one of those type of people that we need that, and when you get bad news like a diagnosis like this, you step up and take the bull by the horns to do what needs to be done to fight back, so to speak. So I appreciate that about you. Why are you here with us today talking about COPD?
Because COPD is really the other epidemic in rural America. It is a significant major disease in all of America. It is the number 3 killer of women and men in the United States. 16 million have been diagnosed with COPD. Another 12 to 15 million have COPD, but don't know it, have not been diagnosed yet. And as bad as it is nationally in America, it is twice as bad in rural America.
Oh, wow.
8.2% of rural Americans have been diagnosed with COPD, and access to treatment in rural America is not what it should be. It is not what's available in metropolitan America. So it really is a national emergency, but it's on no one's radar right now. And we are we are making some progress, but when you have half of the people who have the disease who are not yet diagnosed with it, they're not diagnosed until they've lost more than half of their lung function. It's progressive. That lung function that you've lost does not come back. It is treatable, but only if you're diagnosed.
Yeah, so it sounds like diagnosis is a key there, which I'm sure we'll be talking about later in the conversation. But those numbers are definitely staggering, especially when you compare urban and rural numbers. Are there any other specific groups within the rural population that are impacted by COPD?
Absolutely. Native Americans, veterans, and people who live in geographic areas. For example, Appalachia and the South has the highest incidence of COPD in the nation.
Wow.
Women are affected more than men.
Really?
5.6% of women are diagnosed with COPD, 4.4% of men. We always thought of it as an old man's disease.
Right.
But it is a disease of great disparities. Being poor and living in rural America is an independent risk for COPD. And of course, smoking is higher in certain of these areas as well. Sure. But it's important to note that 1 in 4 who are diagnosed with COPD, so 25% of everyone diagnosed with COPD, has never smoked a cigarette. So it is a disease of smoking if you've smoked. But there are too many of us who have COPD who have never smoked. Now, some of us have the genetic variety, maybe 2% of all who are diagnosed. And there's much we don't know. There's much we don't know about the disease. It is not curable. But as I said, the headline is it's treatable, and we must get people diagnosed, and we must get people in rural America to have access to the same standard of care, of evidence-based care that is available now all throughout the United States.
Well, one of the things I love about you, Grace Ann, is that you've, as I mentioned earlier, you are taking a leadership role in fighting the good fight about sharing information about COPD. And the Rural Health Leadership Radio does have leadership in its name, and I emphasize leadership. And I always ask each guest what their definition of leadership is. So let me ask you what your definition of leadership is.
Well, mine is a combination of a number of quotations that others who are far wiser than I have spoken over the years.
I love your humility too.
Well, I believe it's empowering and inspiring others to achieve shared objectives and visions and instilling hope in the hopeless. And I take this because Father Hesburgh, the absolutely great president of Notre Dame, said every leader and leadership must have a vision. Napoleon long ago said, a leader is a dealer in hope. Bill Gates said, as we look to the next century, leaders will be those who empower others. And perhaps the one I love the best goes way, way back in time, classical Chinese, maybe 10th or 11th century. Lao Tzu said, a leader is best when people barely know he exists. When his work is done, his aim is fulfilled, they will say, we did it ourselves.
Yes, I love that too. That's a great one. Thank you so much for sharing your perspective on leadership. What do we need to know about COPD?
There is so much to know about COPD, but the most important thing to know is that anyone who breathes actually can get COPD, because we have this very large number, 25% of people who've never smoked cigarettes. We always assumed it was a consequence of smoking, and a great deal of it is. But we cannot ignore that in this country, people who've never touched a cigarette are getting it, and it's related in some way to their occupations and to the very air that we breathe. So we've known for a long time, too, the coal miners not only get black lung, but also COPD. We've known that people who work in the furniture and varnish industry inhaling fumes may get COPD. There are many occupations, farming, where we're exposed to chemicals and pesticides that also put us at risk for COPD. But I said to you, there are many unexplained risks for COPD. The scientists have come to think that it's a lifetime event. So, for example, if you were exposed in the womb to dust and particles and gases, if you have a low birth weight or many respiratory infections as a child, you do not start out with the same lung development that others do. So it is a lifetime disease, and COPD doesn't show up in your lungs, or at least you're not aware it's in your lungs until you're in middle age. So it typically hits in the 40s. If you have the genetic disease, you may be in your late 30s. And you'll notice that you're not able to easily do the things you did before, and you think, gee, I'm just getting a little bit older. It's harder to walk, harder to go up a flight of stairs. You become short of breath, coughing over a protracted period of time, bringing up a lot of mucus. These are the symptoms of COPD that we dismiss because we think, you know what, I should have gone to the gym more. So finally, it reaches a stage where we've lost enough lung function that we go to our doctors. And that's why we're typically not diagnosed until half our lung function is gone. And as I told you, it doesn't come back.
Yeah, that shocks me that 25% of the people diagnosed with COPD are not smokers. Because like you said, I was always under the assumption that if you had COPD, it was because you smoked. That's obviously not the case. I mean, it is the case, but it's not the only case, I guess, is a way of putting that.
It is. And many who develop COPD may have stopped smoking 10 or 20 years before. Mm-hmm. They say that if you've smoked 100 cigarettes in your lifetime, you're at risk of developing COPD.
Wow.
If you heat your home with solid fuels are used as a primary source of heating for 2.5 million homes. That's 6.5 million people. Well, that indoor pollution is certainly a contributing factor for COPD. And in rural areas, many still heat their homes with either coal or wood or coke.
Yes. Very interesting. As I think a lot of people share the false assumption that I have always thought that, COPD and smoking were, one and one. And therefore, I think there's a bit of a stigma associated with COPD. Can you talk about that?
Yes. We have moved beyond stigma for so many diseases, sexually transmitted diseases, HIV, AIDS. And somehow there is this lingering sense of stigma for COPD. And I think we've outgrown that. I think if we're going to stigmatize anyone, we should stigmatize the tobacco companies because for decades they insisted that smoking cigarettes had no consequences, that the nicotine was not addictive and the disease was not a consequence. And we actually know that is not true. When I think about stigma, I also think about other diseases that are stigma-free. Heart disease, it is a risk factor for developing heart disease if you smoke cigarettes. But somehow, those who have cardiac disease are relieved of this burden. We don't say, when someone says, I have a serious heart condition, we don't say, well, did you smoke? We don't say, how many Big Macs did you have every day?
Right. Yes.
Aren't you grossly overweight?
Yeah.
Maybe obese. So I think it's time to step back and look at the faces of the people who are dealing with struggling for breath and say, is this a punishment that people should have to endure, or should I offer empathy? And I believe that empathy is what we need. We do not need sympathy. We need support, and we need empathy, and we need empowerment so that we can speak out to others about our condition and so that they can see us as people, not as a disease.
Yes, well spoken there. Too many times we want to be judgmental when we should be more empathetic, more caring human beings instead of placing our judgments on other people. So thanks for talking about that. COPD in rural America, as you said earlier, has been diagnosed at twice the rate as that in urban areas. What needs to be done?
Well, I think we have good blueprints right now as to what needs to be done. And I believe these blueprints come from federal agencies with the collaboration of communities and states in forming them. So we now have, spearheaded by the NIH, the Lung Division, the National Heart, Lung, Blood Institute, and by the Center for Disease Control, the CDC, we have a national action plan for COPD. And that national action plan is a roadmap that involves every stakeholder. It involves researchers, patient groups, advocacy groups, clinicians, providers, payers. If I've left anyone out, I certainly don't mean to, but certainly it is a roadmap for what we can do to empower patients, improve research, and get the message out, raising awareness throughout the country that there are things that can be done. We also have, and it was just released in December of 2018, we have specific policy recommendations that were made by the National Advisory Committee on Rural Health and Human Services that would get the message out in rural America, and it's called Reducing the Burden of COPD in Rural America. There's 3 policy recommendations. One is a national awareness campaign endorsed, hopefully, by Secretary Azar and implemented by Health and Human Services to educate providers in rural areas to recognize the signs and symptoms of COPD, and for patients to understand what the signs and symptoms are, and to enable them then to get earlier diagnosis and better treatment. The second policy recommendation concerns pulmonary rehab. That's the best treatment we have for COPD. We have 3 treatments. We have inhaled medicines. We have oxygen, but only if your blood oxygen is very low. And we have pulmonary rehabilitation, which is an evidence-based program of both education and physical activity that is undervalued by CMS at this point. So the second policy recommendation calls for a fresh look by CMS and by pulmonologists who are lung specialists to understand why there is such a discrepancy between cardiac rehabilitation and pulmonary rehabilitation in terms of reimbursement rates. Pulmonary reimbursement is half of cardiac reimbursement. And certainly we need to look at the underlying costs and what's involved in assessing those costs. And the third policy recommendation is we know we have a shortage of physicians in rural America, is to open up the supervision of pulmonary rehab so that nurse practitioners, physician assistants, and other allied health professionals would be able to conduct the work without the direct supervision of a physician being present in the facility at the time. So I can tell you that we know that pulmonary rehab is not as available in rural America as it is in metropolitan America. And that really is the best treatment that we have for this disease.
Interesting. Can you talk a little bit more about diagnosis and treatment?
Yes, I certainly can. Diagnosis is simple. The policy recommendation called for screening. So certainly doctors have to ask patients about their breathing and be aware, for example, if they were in looking at their history, if they were smokers or what occupations they were in. Did they work in the coal mines? Were they loggers? Are they farmers? To see if they were exposed to risks. So it would involve a good look at the history, screening people, asking people specifically, do you find you're not able to do what you were able easily to do before? Can you walk up a flight of stairs, Joe, without stopping to breathe? And then, if necessary, doing spirometry, which is a breathing test. It's a simple test. It could be done in a doctor's office, and that would tell you whether you have chronic obstructive pulmonary disease or not.
Yeah, because I would guess, Grace Ann, that you said this somewhere along the way. I remember you saying this, that a lot of people probably think, oh, I'm just getting old when they're breathing heavy when they're trying to go up a flight of stairs or something like that. So I would think that would mask the opportunity to make that diagnosis. Is that?
You're absolutely right, Bill. Absolutely right. And spirometry is not invasive. We routinely do, X-rays and blood tests and urine tests and proctology and EKGs but we don't do breathing tests when people are known to be at high risk for developing the disease. And the earliest that we can diagnose this disease, the earlier we can treat the disease, the better the prognosis.
Sure. Yeah, and I think isn't that just a simple test where you blow into a hose, basically, into a tube?
That's right. You blow into a hose as fast as you can and as long as you can.
Right.
And no, that can be done. And again, if it can't be done in the doctor's office, there can be a referral. It can be done certainly in any of the outpatient hospitals. It can be done in critical access hospitals. Some of our clinics, in fact, do spirometry is the name of the test.
Yeah.
But it's a breathing test.
Yeah, would it seem like, patients, I get it, we don't always know what's wrong with us. That's why we go to the doctor, right? So I think that, whatever we need to do to get the provider's attention to look for this disease, to diagnose it, that's got to be the key, isn't it?
Absolutely.
Yeah.
Absolutely.
Okay. So, what are some of the signs and symptoms of COPD? What do we need to be looking for? What do providers need to be looking for?
Providers would be looking for a history of smoking.
Okay.
They would be looking at people's jobs. They would be looking at what risk factors they had in their life. For example, I mentioned many respiratory infections in early childhood, or perhaps in adulthood. Somebody keeps getting chronic bronchitis, and they get it 2-3 times a year. Well, that should be a clue. This person may have COPD. So you would look at the risks that the people have. And many times people, in the short time they have with their doctor, this is at the bottom of the list. But knowing that if you live in a rural area, you have an increased risk of COPD should move this closer to the top of the list. So this should not be a disease where patients don't tell and doctors don't ask.
Yeah, because you think of rural America a lot. You think of the fresh air, right?
Yes.
It's good for you.
Well, the fresh air, depending on where you are, may not be as fresh as you would like it to be.
Yeah. Anything else about signs and symptoms of COPD?
No, I think the primary thing is that you're middle-aged and you're finding it very difficult to do the activities of daily living.
Yeah. Okay. All right.
The next step after that is that all of a sudden you find you really can't walk up the flight of stairs. You really can't walk 50 feet. You can't stop coughing. You're sitting up in bed with pillows behind your back because you can't lie down to sleep because you're coughing so much. So these are all symptoms that you should raise with your doctor, or your doctor should raise with you.
Yeah, that has to be frightening. Not being able to breathe, that's for sure.
I can tell you that
because
I've experienced it many times myself.
Yes.
I have very severe COPD, and from time to time I will get a flu or some kind of a respiratory infection, and when I do, it really knocks me out and takes a while to recover. It's a very, very dangerous disease and untreated.
Yes, and I would think that I know you travel a fair amount. That it has to increase your risk of catching something as you're out and about. So a lot of life-altering aspects of this disease.
Well, I'm very careful. I don't shake hands at all in flu season. I carry the wipes with me, and when I'm in the plane, I've wiped off every surface. If necessary, I'll wear a mask. I'm constantly sanitizing my hands. I try to be very careful, and fortunately, I don't have many respiratory infections. I've survived 18 years with a disease was predicted to kill me within 3 to 5 years, and I do attribute that to lifestyle changes, to pulmonary rehab, and to exercising 7 days a week.
That's incredible. Yeah, that's incredible. So, can you talk a little bit about risk factors?
Well, the risk factors we described. I mean, breathing can be a risk factor depending on where you are. We actually covered that. The risk, but being poor, living in rural America, occupation, former or current smoker, all of these are risk factors for COPD. And if you've been exposed to these risks, you've got to raise it with your doctor.
Very good. Now, you've talked about how pulmonary treatment is one of the keys, one of the better ways of treating COPD. And you mentioned that that's hard to come by in rural America. What are the challenges of treating COPD in rural America?
Well, pulmonary rehabilitation facilities do not exist.
Okay.
They're just not present. And it is a challenge to get them there, but what my husband and I have been able to do with our small foundation, the Dorney Koppel Foundation, is we have found great local partners, other foundations and people in rural America, where the communities have very high rates of COPD and don't have pulmonary rehab, but the community wants it. We partner with them and we co-found clinics, centers in these areas. So they exist now in 5 states, in West Virginia, North Carolina, Kentucky, Maryland, and Louisiana. They do unbelievable work in the rural community. As I said, there are 12 sites, and people are changing. People have had the opportunity, the same opportunity that I had, to transform their lives, to learn about the disease, to recognize when they're coming down with a lung attack. If the doctors call it an exacerbation, it's a change in what is normal for you. And they avoid staying out of the hospital or the emergency room. They regain their physical function, and they're able to have dignity and good lives. And that's what pulmonary rehab did for me, and that's why my husband and I and our partners want to bring it to all the communities that are in great need.
Well, that's outstanding work that you're doing through the Dorney Koppel Foundation. Is there a way? What's the process for a rural community if they wanted to engage in trying to partner with you to do something like that in their community?
Well, first, there has to be a foundation. Our foundation will pay half the cost of establishing it.
Okay.
But unless someone has skin in the game themselves, and it's not something that we fully fund, so that if the community is really interested and the foundation or other partners in the community are really interested, they will come up with half of the funds.
Okay.
And that's what I feel is important, that this is not anything that is imposed on a community. It's something that the community themselves recognizes the need for and is willing to work to achieve. So I feel strongly that the model, this is the only model for rural America. The Grace Ann Dorney Pulmonary Rehab Centers are the only model in this country for rural rehabilitation.
Excellent. Well, we'll make sure that we include your website, the foundation's website, in the episode summary notes. So for any listener who's interested, you'll be able to find that link to find out more. So, Grace Ann, what scares you the most about the future of COPD care?
Well, it is the only disease, major disease. So you've got the number one killer, of course, is heart disease. The number two is cancer. And the number three of chronic disease killers is COPD. You only have COPD where the numbers who have the disease is increasing every year, not decreasing. The others are going in the right direction. What scares me is that we're 30 million overall, 16 million diagnosed, 12 to 15 million or more not diagnosed. It's those not diagnosed ones that scare me. Because unless we come to recognize this lung disease as a national emergency that requires a federal and a state response, unless we realize the need for more research at the NIH, the numbers are just going to continue to grow. So it disturbs me, it scares me, that of all the diseases that exist, and there are hundreds and hundreds and hundreds of diseases, that COPD is funded as number 165 in funding.
Wow.
I find that difficult to deal with because this is a major disease. Why are we 165th in national funding? I'm also scared that people are not getting evidence-based care for COPD, and that this is even more so in rural areas. There are fewer pulmonologists among specialists there, and our family doctors have to be in the front line in treating COPD, and they have to be in the front line of treating every other disease.
Yes.
So we don't have enough family doctors, but we've got to get this on their radar.
Yes, I certainly understand why that scares you. So let me ask you the other side of that question. What gives you hope, Grace Ann?
In the last few years, the Center for Disease Control, the NIH, that is National Heart, Blood, Lung Institute, HRSA, have stepped up and realized the incredible burden that COPD is. We've got this national action plan. That gives me hope.
Yes.
The data that the CDC did on deaths from COPD and hospitalizations and prevalence is shocking. And I note that you noticed that too today. It is shocking. You say, how can this exist? How can this be? I do believe that with federal agencies, if everyday people who have this disease, look, if there are 16 million of us, why don't we speak out?
Yes.
What gives me hope is that the spotlight is on this disease. We have the resources that we really could manage it better. And I am more hopeful now than I have been since 2001 when I was diagnosed with the disease, that we will make progress. And at the end, I always want to say what gives me hope is it's treatable. We don't have a cure, but we do have treatments that can control symptoms. And one day, I do believe we are going to have a cure if enough of us speak out loudly enough to our legislators, to anyone who will listen.
Yes, and I think one of the reasons we have this hope is because of people like you, Grace Ann, who have stepped up and taken a leadership role in conveying that message and making those conversations happen. So thank you for your work in that area. You know, it's the time has flown by. We've talked about a lot of different things during our conversation today. If our listeners only take one thing away from the conversation we just had today, what should that be?
Do not dwell on the negative, dwell on the positive. Let the knowledge that it is treatable make you come forward, both as a provider or as a patient or as someone who loves a patient. That's what I want you to take away, is that I want you to take away that there's hope. And I want all of you to feel that you did it yourself.
Grace Ann Dorney Koppel, president of the Dorney Koppel Foundation, immediate past president of the COPD Foundation, and presently board member of the COPD Foundation as the chair of advisory and policy. Thank you again for joining us today and sharing your expertise and knowledge on COPD, particularly in rural America.
Thank you very much, Bill. It's really been a pleasure.
And I want to thank all of you out there for listening today. If you enjoyed today's episode, please go to iTunes, Stitcher, Google Play, whatever your favorite podcast app might be, and subscribe to Rural Health Leadership Radio. And if you'd like to continue the conversation of leadership in rural health, you can also join our LinkedIn group called Rural Health Leadership Radio. And while you're on Facebook today, we also appreciate likes on our page, so give us a like on Rural Health Leadership Radio's Facebook page. Until next week, let's keep working to improve rural health, one conversation at a time.
If you would like to connect with today's guest, please send an email with your contact information to bill@billoxier.com. If you would like to be a guest or suggest someone else as a guest, have a question you would like to ask, or simply want to contact Rural Health Leadership Radio, please use that same email address, bill@billoxier.com. That's BILL@BILLAUXIER.com. You can also visit our website at www.rhlradio.com.
And we'd ask that you please support our sponsor, the Dynamic Leadership Academy for Rural Health. The Dynamic Leadership Academy for Rural Health's mission is to improve rural health, one leader